Hello and welcome back to Unacademy. So let's get NEET PG. Myself, Dr. Muskan Chaudhary, and today we'll discuss the question answers for that of the mycology. Okay, so starting with Unacademy. Unacademy is India's largest learning platform where we get access to both the live and the recorded session, learning from the India's topmost educator for any medical examination, be it NEET, UG, or the PG, competing in the live T&Ds, studying on the device of our choice, and assessing 25,000 of MCQ with printed and digital notes. Under Icon subscriptions, Unacademy Tablet has come together with clinical integrated essentials, video lecture QBanks, rapid revision notes, and the 2022 Dream Notes with well-structured live batches, recorded classes, Q banks, and the competitive T&Ds. Now, under NEET PG Plus for 2 years, it will cost us around rupees 36,000. That will be around 1,500 per month and 1250 for 36 months. For Iconic, it will be around 58,500. For 2 years, it will be 2438. And please do use my code, that is Muskan10, to get 10% of the further discount. Yes, so starting with the highly effective Q banks and the based on latest examination pattern with detailed explanations. Special class features include the interactive live sessions. We can do the polling for the learners, raise a hand feature, talk to educator, and get doubts that resolve within the time, real time, and get notified for the upcoming lessons and the courses and the recommendations. Lecture notes download. We can download the lecture notes and get access to recorded sessions anytime and anywhere, and participate in the live chat and gets a doubt clear. That is all during the live classes. Target NEET PG 122 batches, that is has been started from the December month, and with well-structured modules and the clinical questions, recorded sessions, Q banks, and the practice questions. Focus FMG 2022 batches with well-structured batches, FMG GTs, recorded sessions, Q banks, and the practice questions with 24,000 of the MCQs. Now we'll start with the question. Okay. So, some around 20 questions we already did in one of the previous classes for the fungus. So, we'll start with the next question. So, first question of the day. Yes. So, starting with the first question, that the yellow granules are seen in which fungal infection? That is the Mucormycosis, Mycetoma, Aspergillosis, or Rhinosporidiosis. So, please let me know the answer in 15 to 20 seconds, and we'll discuss the answer. That yellow black granules are seen in which of the following fungal infections? Yes, so what will answer? The yellow-black granules are seen in which of the following fungal infections? That is a mucormycosis, mycetoma, aspergillosis, or the rhinosporidiosis. So now talking about the granules, now we have two classes. One is the actinomycetoma. That is the causative agent is what? Bacterial. That is the causative agent. That is the gram positive. And then we have the Eumycetoma. There we have the fungal as the causative agent for the Eumycetoma. And talking about the actinomycetoma, all the agents of the actinomycetoma that produce the white to yellow granules, whereas that of the Eumycetoma, they produce either the white or the black granules. What is the answer? That is the mycetoma producing what? The yellow black granules. Now color of the granules that is produced by the Actinomycetoma is black, yellow, blue or white. Yes, so what will the answer? The color of the granules that is produced by the Actinomycetoma, the color of the granules that is produced by the Actinomycetoma is what? White to yellow granules. Apart, but one exception is there. One exception is there, that is the Actinomycetoma, Actinomadura palletri, that produces what? The red to pink granules. So actinomycetoma is producing what? It is producing the white to yellow granules that is produced by the actinomycetoma, and it is what causative agent is one of the gram-positive bacteria. One exception is over there, that is the Actinomadura palletri, that is producing the red to pink colored granules. Next question, true about the mycetoma. It's commonly occurring in the hands and commonly erodes the bone, drains through the lymphatics, and antibiotic has no role. It's a PJ question, so more than one option will be correct in this one. That true about the mycetoma is. Now talking about the mycetoma. Now mycetoma is what? It is a slowly progressive. It is slowly progressive chronic granulomatous disease. A slow progressive granulomatous infection of the skin and the subcutaneous tissues, and including the that is commonly occurring in the hands and the peripheries, and mainly in the hands and the palms and the soles. And what is the causative agent for that? We have talked about, that is actinomycetoma, the eumycetoma. Act for the actinomycetoma, it is a gram positive bacteria, and for the eumycetoma, fungal agent. And it affects extremities like the hands and the foot, which are more prone because they are more prone for the accidental trauma, therefore involving the hands and the foot. Mainly, it is an occupational disease commonly occurring in the farmers who carry the goods on the head and the back. So it commonly occurs in the heads. It doesn't commonly erodes the bone. Um, Drain through the lymphatics. No, this is also not the true answer, and it do involves the bone, and antibiotic has no role in that because of the main talking about the mycetoma, that can be caused by both the fungus and the bacteria. So if it is caused by the bacterial agent, antibiotics will do have the role in that case. So this is also not a true statement saying that antibiotic has no role. Now talking about the actinomycetoma, that is caused by the bacterial agent, for that the drug is given, that is we give the drug like the streptomycin and cotrimoxazole. Now the next question, actinomycetoma is caused by the actinomyces nocardia, streptomyces or madura mycosis. Yes, what will the answer? The actinomycetoma is caused by which of the following agents? Now, actinomycetoma, that the causative agent is the bacteria, that is the gram-positive bacteria. And what is the main causative agent for the actinomycetoma? We talked about that they produce the yellow to white color granules. Exception is what? Madura pellets that is producing the pink colored granules, pink to red colored granules, and actinomycetoma that is caused by the nocardia and the streptomyces. And the next question, Ectothrix is due to the Trichophyton tonsurens, Microsporum ordini, Trichophyton sholani, or Trichophyton violaceum. Yes, what will the answer? We have talked about two types of, that is the Ectothrix and one was the endothrix. Now, Ectothrix, that is the arthrospores, are present over the hair shaft, and in the endothrix, it is present in the hair shaft. And in is what in that, what are the causative agents for the Ectothrix and the endothrix? For the endothrix, we were having the TVS, that is the Trichosporum sholani. We have ended V for that is the violation, and another T, that is the tonsurens. So tonsurens, sholani, and the violation, they are agents for the endothrix. All right, then we have the Microsporum ordin, because Microsporum species and the rubrum, they are the causative agent for the Ectothrix. So what is the correct answer? That is the Ectothrix is due to the Microsporum and the this rubrum. True about the Mycetoma is it is a fungal infection. It is presented as a non-painful nodular lesion for the many months. It has discharging sinus and bone involvement is seen. So again, if more than one option can be true in case of this, it's a PJ question, that which of the following statement is true about the Mycetoma. Yes, what is the correct answer? That true about the Mycetoma, which of the following statement is true? This is a fungal infection. Yes, present as a non-painful tender nodular lesion for many months. True. It has a discharging sinus too, because it is one of the Eumycetoma, and bone involvement is commonly seen because starting within of the skin, subcutaneous tissue, fascia, and then spreading to that of the bone. Now, the granules that is discharged in mycetoma contains the bony specules, or the fungal colonies, pus cells, or the inflammatory cells. So, the granules discharged in the mycetoma contains what? Now, the granules that is start whether in the Actinomycetoma or the Eumycetoma, they are the cause of the they are the causative agent, and they are responsible for the discharging granules that contains the causative agent. And mycetoma, that is we are talking about the fungal colonies. Now, discharge granules in the mycetoma, they are nothing but they are the microcolonies. They are the microcolonies of the causative agent, and therefore the color of the granules they actually differs according to the etiological agent. Now, move to the next question. A farmer presents with the multiple discharging sinus in the leg not responding to the antibiotics. Most likely diagnosis is it is a medulla actinomycetoma, nocardia, or the Sporotrichosis. Yes, what is the answer? A farmer presents with the multiple discharging sinus that is not responding to the antibiotics. What will the correct answer? Now, multiple discharging sinus not responding to the antibiotics suggests the diagnosis of the Eumycetoma, because if it was Actinomycetoma, it would have responded to the antibiotics. Since it is not responding to antibiotics, it is what? It is Eumycetoma, that is the medulla mycetoma, not Actinomycetoma or the nocardia. Which of the following organism is implicated in the causation of the Botryomycosis, that is a Staph aureus, Staph albus, Pseudomonas aeruginosa, Streptococcus pneumonia, or Streptococcus pyogenes? Hmm. Yes, so talking about the Botryomycosis, which is the chronic and purulent granule producing granulomatous infection. Okay, so Botryomycosis is a chronic purulent granule discharging, that is a granulomatous infection of the skin and the subcutaneous tissue, and neutrophilic reaction is present, and treatment is the giving the antibiotics. And what is the causative agent? The causative agent is what? The Staphylococcus aureus and the Pseudomonas aeruginosa. That is a causative agent for the Botryomycosis. And we have, apart from the Staph aureus and the Pseudomonas aeruginosa, it is the E. coli proteus are also, and even the non-hemolytic streptococcus, even they are also the causative agent for that of the Botryomycosis. The causative agent for the recurrent ulcer in the subhumale region is the Cladosporium sportrix Chromoblastomycosis or the mucor. Yes, the causative agent for the recurrent ulcer in that of the subhumale is even, that is we are talking the Sporotrichosis, because Sporotrichosis that is seen in the subhimalayan region and it is by the traumatic inoculation. It is by traumatic inoculation of the spores, and we get what cigar shaped arthrospores, and it is what it is a chronic granulomatous ulcerative nodular region that is seen along the extremities and that have the a systemic pattern of draining along the lymphatics. Talking about what Sporotrichs shanky, which is also known as the rose gardener's disease, and typically found in that of the Himalayan and the sub-Himalayan region. Now, cigar shaped body is seen in the Cryptococcus or the Sporotrichosis, Histoplasmosis, or aspergillosis. Cigar shaped asteroid body, cigar shaped asteroid body is seen where? In the Sporotrichs shanky, that is again one of the dimorphic fungus, which is also known as the rose gardener's disease. Next, sclerotic bodies are found in the Rhinosporidiosis, Histoplasmosis, Coccidomycosis, or the Chromoblastomycosis. What is the answer? Sclerotic bodies are seen where? Now, sclerotic bodies, that is also known as the medlar bodies or the copper penny bodies or the muriform cells. They are nothing but they are seen where? In the chromoblastomycosis, and they appear just like the copper, having the thick copper colored, brown colored, copper colored outline of the cell wall, that is a copper penny body seen the chromoblastomycosis. A gardener has the multiple vesicles on the hands and the multiple eruptions on the lymphatics. Most common fungus that is responsible is Sporotrichs shanky, Cladosporium, Histoplasma, or the Candida. So Gardner, that is having the multiple vesicles on the hands and the multiple eruptions that is along the lymphatics is the characteristics for the Sporotrichosis shanky or the rose Gardner's disease. The most fungal responsible is the Sporotrichosis shanky, and again it is it is diamond fungus that is the yeast form at 37 and the mold form that is as 25 degree Celsius. Okay, one of the best way to differentiate the clinically between the Eumycetoma and the Actinomycetoma is the duration of the illness, severity of the illness, or the nature of the discharge, or it cannot be differentiated clinically. Yes, what is the answer? One of the best way to differentiate clinically between the eumycetoma and the actinomycetoma is based upon the nature of the disease. Because talking about the eumycetoma, that is the serous in nature, and talking about the actinomycetoma, that is what purulent in nature. So, depending upon the nature of the discharge, we can differentiate clinically between the eumycetoma and the actinomycetoma. True about the Rhinosporidium seabear is a fungus, it is a bacteria, ketoconazole is a treatment, and the present in the coastal India. So, which of the following is the true statement? Yes, which of the following is true statement about the Rhinosporidium seaberry? Now, Rhinosporidium seaberry, it is one of the controversial because it is sometimes considered as a fungus, sometimes considered as that of the protozoa, and it is found where in the coastal areas. And the ketoconazole is not the treatment for that of the Rhinosporidium seaberry because antifungals cannot be given for that of the Rhinosporidium, and neither it is a bacteria, neither it is considered as to be fungus. Now, Rhinosporidium was thought to be fungus, but based upon the molecular studies, it is now considered to be as the parasite and the Protestian parasite. And infection is acquired by coming in contact with that of the fresh or the stagnant water. Hence, it is believed as a hydrophilic Protestian parasite, and it will be present in the coastal areas in the India and the Sri Lanka. And the Rhinosporidium seaberry, the person will present with the vascular polyp which will bleed on touch. And what is the most common site? The most common site is nose followed by that of the conjunctiva. And we can see the white studs over the polyp, and these white studs are the nothing but they are the spherules containing what? Sporangiospores. And it is common in India in the coastal areas in Tamil Nadu, in the Kerala and the Andhra Pradesh, and that is considered to be as the Protestian parasite. Now, moving to the next question, Darling's disease is caused by the Histoplasma, Candida, Cryptococcus, or the Rhizopus. Yes, easy one. Darling's disease is another name for the histoplasmosis, and it is also one of the dimorphic fungus. And what was the mnemonic for the dimorphism? That is HSP. BC, that is H for the Histoplasma capsulatum, and it is misnomer because it is not capsulated. Right, another S is Sporotrichosis shanki. Then we have P, Paracoccidiomycosis and the penicillin marnifi. And what else we have? B for Blastomycosis and C for coccidoid mycosis. So Darling's disease is what the other name for the histoplasmomycosis. So, most common deep mycosis in India is the histoplasmosis, blastomycosis, coccidomycosis, or the cryptococcus. Now, what is a deep mycosis? That is both systemic plus opportunistic. So, most common deep mycosis in India. Now, both systemic and the opportunistic infections are together called as the deep mycosis. And among वैसे तो candidiasis, that is the most common deep mycosis. Now, amongst histoplasmosis, blastomycosis, or the coccidiosis, they all are the dimer fungus. They are the systemic one, but they are not the opportunistic one. So, deep mycosis, that is the cryptococcus, that is both systemic as well as the opportunistic one. Now, which is true about the histoplasmosis, that is in early stage, it is indistinguishable from the TB. Culture is not diagnostic and mycelial forms are infectious form. Person to person spreads occurs by the droplet infection. So, which of the following is true statement about the histoplasmosis? Talking about the histoplasmosis, that is a histoplasma capsulatum, another dimorphic fungus, and it is in the late stage, in the chronic stage, that is, it is indistinguishable from the TB. Culture is the diagnostic. By the culture, we can diagnose the histoplasma capsulatum, and the mycelial forms are the infectious forms, and person to person transmission is not seen in case of the histoplasma mycosis. Now, endemic fungal infection is coccidioids immitis or the Cryptococcus, histoplasmosis, aspergillus, or the blastomycosis. Again, more than one option will be true for this one. Now, talking about the endemic fungal infections, that is fungal infections that is confined to particular geographical areas, confined to particular geographical areas, and amongst this, the most of the dimer fungus, they are the endemic one because they are found in particular areas of the world. So talking about that, that is the coccidioids immitis. Then we have the histoplasmosis and the blastomycosis. Now, histoplasmosis that is found mainly in the central and the southeastern US. Now, the blastomycosis that is also known as the North American disease. And what is the another name? That is the Gilt Christ disease. And talking about the coccidioids that is found in the Central and the South America. So we have the coccidoids that is found. Now talking about the Cryptococcus and the Aspergillus, they are the deep mycosis. They are the opportunistic one as well as the as well as systemic one, but they are not the endemic. We have the coccidoids, Histoplasma capsulatum. Then we have the blastomycosis, Cryptococcus, penicillin. They are what? They all are the endemic fungal infections found in a particular geographical area. True about the Histoplasma capsulatum, it is a dimer fungus causative organism of moneliasis, causative organism of the valley fever, or capsulated. So, the following statement is true about the Histoplasma capsulatum. It is a dimer fungus is true because we have the pneumonia that is HSBPC, and the Histoplasma capsulatum is a dimer fungus that is having yeast at 37 degrees Celsius and the mold form that is around 25 degrees Celsius. The causative organism for the moneliasis is what? It is the Candida, not the Histoplasma. The causative organism for that of the valley fever is the coccidioids. That is also responsible for causing what? Desert rheumatism. Desert rheumatism and the valley fever, that is by the coccidioids, and it is a misnomer, it is not capsulated. The only fungus that is capsulated is Cryptococcus. Raynaud's broad phenomenon is seen in the Candida albicans, Candida histoplasma, or the Cryptococcus. Yes, what is the answer? Raynaud's broad phenomenon, that is another name for the germ tube test, and it is positive in the Candida. It is positive in the Candida albicans and Candida dubliensis. Alright, apart from the Candida albicans and dubliensis, germ tube test they also shows corn meal agar growth that is also seen by both. And how to differentiate between the albicans and dubliensis, because clinically they are often confused by looking at the growth at 45 degrees Celsius, which is seen by the Candida albicans. Most common fungal infection in non-HIV infected person is Candida, Cryptococcus, Mucor, or the Aspergillus. Yes, what is the correct answer? Most common fungal infection in the non-HIV infected person is. It is what the most common fungal infection in HIV, non-HIV or HIV, whatever it is immunocompetent or the immunocompromised, it will be Candida. Now, a vitreous aspirate from a case of the metastatic endophthalmitis on the culture yields the gram-positive round to oval cells, 12 to 14 micro in size. The aspirate on the gram staining shows the presence of the pseudohyphae. Which of the following is the most likely the etiological agent, that is Aspergillus, Rhizopus, Candida, or the Fusarium? Yes, what is the correct answer? Now, vitreous aspirate from the case of the metastatic endophthalmitis is a gram positive. Now, first point is that gram positive, and the aspirate on the gram staining shows the presence of the pseudohyphae. So, we are talking about the candida, because candida is what? An yeast-like fungus. Candida is an yeast-like fungus, and it is not a true fungus. That is, it is having the true yeast. It is having what? Pseudohyphae. And what else? It is gram positive, responsible for causing the metastatic endophthalmitis. Whereas the Aspergillus rhizopus or the Fusarium, that whatever the options they are not having the pseudohyphae, they are the molds form or the filamentous form that is having the true hyphae. An HIV positive female presents with the indurated ulcer over the tongue. Laboratory finding shows the growth in the cornmeal agar at 20 degrees Celsius. Microscopy shows the hyphae and the growth in the human serum at 37 degrees Celsius, showing the budding is the probable cause is Candida albicans, histoplasmosis, blastomycosis, or the coccidioidomycosis. Yes, what is the answer? HIV positive female presenting with the inverted ulcer over the tongue, and that is growth over the cornmeal agar, and showing the hyphae and the growth in the human serum at 37 degrees Celsius, showing the budding yeast form. So we are having the inverted ulcer with the cornmeal agar growth at 20 degrees Celsius and showing the growth at human serum 37 degrees Celsius, showing the budding yeast form. That probable cause is what? The probable cause is the Candida albicans. The history of the oral ulcer, oral thrush in case of the immunocompromised person suggests one of the opportunistic one. And amongst the histoplasmosis, blastomycosis, or coccidioid, they all are the dimer fungus, but they are not the, they are systemic fungus, but they are not the opportunistic one. Candida is one of the opportunistic one with the growth over the cornmeal agar and showing growth at 37 human serum. Most common fungal infections in the febrile neutropenia is Aspergillus niger, Candida mucormycosis, and the Aspergillus fumigatus. So febrile neutropenia, that is fever is more than 38.5 degrees Celsius, and the neutrophil counts will be less than what? 500 per microliter. So that is the talking about the febrile neutropenia. And what is the most common fungal infection in the febrile neutropenia? Yes, what is the answer? The most common fungal infection for the febrile neutropenia is what? The Candida. Candida is the most common fungal infection in the febrile neutropenia. Which fungal infection spreads in the neonates to the caregiver's hand? That is a Candida albicans, Candida parapsilosis, Candida tropicalis, or Candida glabrata, or it is Cryptococcus. So, which fungal infection spreads in the neonate through the caregiver's hand, that is the Candida parapsilosis, is increasingly responsible for the hospital outbreaks, and mainly it is by the caregiver's hand that is spreading in the neonates. Which of the following is only is, that is a Candida mucorrhizopus or the Cryptococcus? So which of the following is the true pathogenic yeast is what? True pathogenic yeast. Which is the following is the true pathogenic yeast? It is what? It is the Cryptococcus. Rest Mucorrhizopus and the Absidia, they are the zygomycetes and they are the mold form or the mycelial form. Candida is yeast like fungus. It is not true yeast. It is what? Yeast like fungus. Budding is seen in the Cryptococcus and Candida, Candida or Rhizopus, Rhizopus and the Mucor Candida or the Aspergillus. So budding is seen with. Yes, so budding will be seen in the yeast as well as the yeast-like fungus. So that is yeast, that is the Cryptococcus, and yeast-like fungus, that is the Candida. Rhizopus, mucus, Aspergillus, they are what? They all are the mold form that doesn't replicate by the budding. Budding will be seen in the yeast and the yeast-like fungus because Candida that replicates both by the binary fission as well as the budding form. The capsule of the Cryptococcus neoformans in the CSF sample is best seen by the gram stain, indine preparation, Jamesa stain, or the methanamine silver stain. So is even the capsule Cryptococcus is what? A capsulated, only capsulated fungus. And it is one, it to stain the capsule, we use the nigrosin stain or India ink stain or the negative stain where the background will be black against which the capsule they will appear as a refractile white halo appearance against the dark black background. So we use what? We use the India ink preparation to stain the capsule. Now apart from this, to stain the cell wall of the Cryptococcus, we use the mucicarmine stain. And other stains like we are using the Giemsa stain to stain the other fungus and the Cryptococcus, but we are not using the gram stain. We are using the Giemsa stain, GMS stain, PAS stain to stain the Cryptococcus. But for the capsule, we are using the indine preparation or the negative stain or the nigrosin stain. The most common organism among the following that cause the acute meningitis in the AIDS patient is the Streptococcus pneumonia, Streptococcus agalacti, neoformans, or the Listeria. So, Cryptococcus neoformans is the responsible most common organism that is responsible for the acute or the chronic meningitis, acute or the chronic meningitis in the HIV or the AIDS patient. Apart from that, over the skin, it is responsible for causing what? The molluscum contagiosum, like lesion that is the Cryptococcus neoformans, and it easily cross the blood-brain barrier, therefore responsible for causing the acute and the chronic meningitis. And the Cryptococcus, we have the Cryptococcus neoformans and the Cryptococcus gutti, and we also differentiated some points that neoformans is worldwide in distribution. It is mainly seen in the tropical and the subtropical countries, and apart from this, it is found in the soil that is enriched with the pigeon or the bat, bird's excreta, and it is found in the soil that having the eucalyptus tree. Also, it is easily treated by the antifungal, while the gut tea that is difficult to treat. Cryptococcus can be readily demonstrated by the Albert stain, India ink stain, Jamesa stain, Gram stain, or the Zn stain. Yes, what is the answer now? Cryptococcus is readily demonstrated by the indirect stain or the negative stain or the nigrosin stain. Apart from this, we use the mnemonic nap that we use to stain the Corneobacterium diphtheria. That is the that is an sorry, Albert stain to stain the volutin granules. Volutin granules or the metaphosphate granules or the bichromatic granules in the Convectin diphtheria, we were using the Albert stain. Now, Zedin staining, that to stain for the mycolic acid, and the Gram stain for the gram positive, gram negative, and the Jamesa stain for the histopathology. We are using the India ink stain to stain the Cryptococcus and mainly to stain the capsule because it is the only capsulated fungus. Now, neutrotropic fungus are the Cryptococcus neoformis, Histoplasmosis, or the Trichophyton candida, or the aspergillosis. So, neurotropic fungus is hmm, which yes, neotropic fungus. Which of the following is neotropic? We have altopic cryptococcus because it crosses the blood-brain barrier, responsible for causing the acute and the chronic meningitis, mainly in the HIV or the AIDS patient. Now, talking about the next option, that is the histoplasmosis, also have the features of the CNS invasion. Then, talking about the Candida and the aspergillosis, because Candida and the aspergillosis, they are the deep mycosis, that is they are what they are systemic plus opportunistic infection. So is the Cryptococcus neoformans. Trichophyton is not a neurotropic because it is superficial mycosis that doesn't have the systemic invasion, and it is one of the dermatophytes. Latex agglutination study of the antigen in the CSF helps in the diagnosis of the Cryptococcus, candidiasis, aspergillosis, or the histoplasmosis. So latex agglutinin study we use for the antigen in the CSF, we use for the Cryptococcus antigen, and for that we use the latex agglutination study for the Cryptococcus antigen. Because the antigen titer in the CSF stays for the longer duration, and it is directly proportional to that of the mortality of the patient. Cryptococcal meningitis is common in the renal transplant recipient or A-gamma globulinemia, neutropenia, or IgA deficiency. Yes, cryptococcal meningitis is common in now there are certain individuals who are at risk. Now that is the patient with the hematological complications. Then next are the recipients of the solid organ transplantation, and which requires the immunosuppressive therapies, and the patients who are on the steroids or the glucocorticoids therapies, and the patients with the HIV infections. So renal transplant recipients, they form one of the common agent for the cryptococcal meningitis. Drugs that is used in the treatment of the aspergillosis is itraconazole, voriconazole, cotrimoxazole, amphotericin B, or the ketoconazole. Now it is a PJ question. More than one answer can be true for this one. So please let me know the drugs that is used in the aspergillosis. We use itraconazole and the voriconazole as well as the amphotericin B for the treatment of the aspergillosis, one of the deep mycosis that is called systemic, as well as the invasive mycotic fungal infection. And mainly what the treatment that we give, it is the agent against the aspergillosis we use is the voriconazole, itraconazole, as well as the amphotericin B. Voriconazole is preferred over the other two drugs, but they are also given. Alpha toxin is produced by which of the following aspergillus flavors, Niger, Candida, or the Cryptococcus or Nocardia? Alpha toxin, that is the mycotoxin, produced by one of the fungus, that is. Now, alpha toxin that is produced by one of the aspergillus, that is Aspergillus flavus. and it is also one of the causative agent for the paranasal sinusitis by the aspergillus, causing the paranasal sinusitis, that is the aspergillus flavus. The most common agent of the aspergillus, that is the aspergillus fumigatus. And what is the most important risk factor in the aspergillosis is the neutropenia. And what is the most common sign? They causes what? They are causative agent for the brain abscess. They easily cause the brain abscess and the paranasal sinusitis, as well as the onychomycosis or the paranasal sinusitis, the aspergillus flavus, aspergillus niger causing the onychomycosis, and the brain abscess. Most important risk factor is the neutropenia and the aspergillus fumigatus, that is the most common agent, that is the aspergillus. What is important again for the aspergillus? That is A for A. They shows the acute angle branching. This is automycosis, sorry. That is the acute angle branching with the septate hyphae. They shows what? They shows the septate hyphae and they shows the acute angle branching, that is by the aspergillus flavor, aspergillus. A 25-year-old female complains of the recurrent rhinitis, nasal discharge, and the nasal blockage since 2 years. She has a history of asthma and the allergy. On the examination, multiple ethmoidal polyps are noted with the mucosal thickening and the impacted secretions in both the nasal cavities. Biopsies is taken and the material is cultured, which shows the growth of many hyphae and the pseudo hyphae with dichotomous branching, typically at 45 degrees. Which of the following is the most likely the responsible organism? That is the Aspergillus, Rhizopus mucor, or the Candida. Yes, what will the answer now? A 25-year-old female complains of the recurrent rhinitis. One point is that we are having recurrent rhinitis, nasal discharge, and the nasal blockage. These are symptoms of the this nasal sinusitis, and she has a history of the asthma and the allergy. And the aspergillus is one of the causative opportunistic infection. If the patient is already had the infections of the like the pulmonary infections or the asthma or the allergy, then the preformed cavities, they form a house for the colonies formation for the aspergillus. Apart from this, the biopsies they shows the branching typically at 45 degree, that is the acute angle branching. So these points they are what pointing towards the aspergillus. Now the rhizopus and mucor, they are the zygomycetes. They are the zygomycetes, and the zygomycetes one is that they are aseptate. They are just opposite of the aspergillus. Aspergillus shows the acute angle branching and they are what septate hyphae. They shows the broad angle branching, obtuse angle branching, and they are the aseptate hyphae. So rhizopus and mucor, they cannot be possible. And then we have the candida, that this is not a mold form, this is a pseudo hyphae form, so that is not the answer. So what is the answer? Correct answer, it is the aspergillus. In the HIV infected individuals, gram stain of the lung aspirate shows the yeast like morphology. All of the following the most likely diagnosis except Candida tropicalis, Cryptococcus neoformans, Penicillin mandiffi, or the aspergillus fumigatus. Guess what is the answer for this one? Now, HIV infected person with the gram stain of the lung shows the yeast-like morphology. Candida, that is the yeast-like fungus. Then we have the Cryptococcus, that is the true yeast. Then we have the penicillin, which is the dimorphic fungus, and it has both yeast and the mold form. Yeast at 37, mold at 25 degrees Celsius. Then the aspergillus, which is the mold form, they have the hyphal form. They doesn't have the yeast-like morphology. So exception pucha, so what will we accept? That is the aspergillus. Rest they all can show the yeast-like morphology. In a patient, corneal scraping reveals the narrow angle septate hyphae. Which of the following is the etiological agent? Mucor, aspergillus, histoplasmosis, or the candida? Now, one point is talking about the corneal scraping, that is the patient might be having something, it is fungal keratitis, and another point is that having the narrow angle septate hyphae, and we talked about acute angle septate hyphae. It's a characteristic A4A, that is the aspergillus. We have the mucor, which belongs to the zygomycetes and which shows the broad angle hyphae with of the aseptate hyphae. This cannot be answered. Then we have the candida might, then it can cause the fungal keratitis, but it doesn't has the septate hyphae. It is having the pseudo hyphae. And the histoplasmosis, histoplasma capsulatum, it doesn't cause the fungal keratitis. So what is the true answer? That is the aspergillus. Common fungus causing the corneal ulcer is aspergillus, mucor, refusarium, or the sporotrichs. Again, one more than one answer can be true in this one PGI question. So, common fungus causing the corneal ulcers. Now, causing the fungal ulcer, corneal ulcer, or the keratomycosis, they are certain agents. One is the Aspergillus fumigatus, as well as the flavus that can cause the keratoconjunctivitis and the keratomycosis. Apart from this, we have the penicillium, we have the fusarium, aspergillus, and this penicillium, right? Mucor and the sportix, it doesn't cause the corneal ulcers. Now, a diabetic patient suffering from the soft tissue infection, the microbiological examinations reveals the infection being caused by with the fungus with the aseptate and the broad hyphae. Which of the following fungus is responsible for the infection? That is the Candida, Aspergillus, Penicillium, or the Apophysomyces. So, diabetic patient, now one is the diabetic patient suffering from soft tissue infections reveals the fungus with the aseptate and the broad hyphae. That is the feature of what? Feature of the zygomycetes. And what all fungus belongs to it? That is the, we have the uh, rhizopus, we have mucor, Absidia, and what is apophyte. So myces, they are all zygomycetes having the aseptate hyphae and broad angle branching and the broad hyphae. Apart from this candida, that is having the pseudo hyphae, not the true hyphae, and then having the aspergillus having the acute angle narrowing branching, and so is the penicillin, that is having the narrow septate hyphae. So zygomycetes, they have the broad hyphae and the branching is also at the obtuse angle, that is the broad angle, and that is belong to zygomycetes. Which of the following is the aseptate fungus? Aspergillus, Candida, Nocardia, and the Rhizopus. So easy one, aseptate hyphae, they are what? Zygomycetes are the aseptate hyphae, and they have the broad hyphae, and they have the Rhizopus, Mucor, and Apsidia, as well as Apophycomyces. Now Rhizopus, they have the nodal rhizoids. Then we have the Apsidia, we having the 2i, that is the intranodal rhizoids. Then we have the mucor amkebad, and that is no rhizoids. And what is the most common risk factor for the zygomycetes? That is the diabetic ketoacidosis. That is the most important risk factor for the zygomycetes. That is the diabetic ketoacidosis, as well as the zygomycetes. They show good growth over the patient having the iron, because they show good growth in the presence of iron. So if a person is having some chelation therapy or consuming iron, so that will have the more chances of having the zygomycetes, because they shows the good growth in the presence of the iron. So what is the answer? That is the rhizopus. Apart from this, aspergillus and the nocardia, they are all having the septate hyphae. With the next question, true about the mucormycosis is nose is a common site. Diabetes is a common predisposing factor. Common in India or all of the above. So true about the mucormycosis is mucormycosis. That means we are talking about the zygomycetes. That is, we are talking about mucor. All right. And what is the most important risk factor for the zygomycetes? That is the diabetes. So this is a true statement. It is common in India, and nose is a common site. That is the rhinocerebral. Sorry, just that was an important message. True about the mucormycosis. The nose is a common site, and it is responsible for causing the rhinocerebral zygomycosis, that is the most common and the fulminant type of the zygomycosis infection, that is affecting mainly the nose. And the risk factor most important, the diabetes, and apart from this patient on the dialysis or having the iron overload therapies, and it is easily common in India. Now, sorry, what did I do? Okay, coming to the next question. Mucormycosis is an angio invasion or lymph invasion, septate HIV long term deforaxamine therapy is predisposing factor. It may lead to blindness. So, mucormycosis, the following statement is true. Yes, so mucormycosis that is one of the zygomycosis, and the angio invasion, it is highly fulminant later that is involving, that is causing the angio invasion. Lymph invasion is not there. It is a aseptate broad hyphae. Long term iron therapy is producing factor along with the if patient is having on the dialysis, or the patient is on diabetic ketoacidosis, or the patient in the deforaxamine therapy. That is one of the important risk factor and the predisposing factor for the mucormycosis, and it may even lead to blindness. Orbital mucormycosis is a complication of the AIDS or the steroidal therapy, Cushing's disease, or the diabetic ketoacidosis. So easy one, which of the following is a complication? Orbital mucormycosis is a complication. The most important complication is the diabetic ketoacidosis. For the mucormycosis or for the zygomycetes, if there's a question, and one of the option is diabetic ketoacidosis, that is the most important risk factor. We have to go with that. Select the false statement about the pneumocystic erovicide that it is seen only in the immunocompromised individuals, frequently associated with the CMV, may be associated with the pneumatocele, and diagnosed with the sputum microscopy. So, which of the following statement is not true? Yes, select the false statement. Now it is seen in only immunocompromised individual. This is the true statement because pneumocystic infection, it is an opportunistic pathogen and it is associated with the pneumatocele. Yes, because pneumocystic it was responsible for causing the bilateral interstitial pneumonia. That is so later in later stages may be responsible for causing the pneumatocele and the pneumothorax, and diagnosed with the sputum microscopy, but it is not associated with the CMV. Which of the following is a fungus? Klebsiella, Clostridia, Pneumocystic erovisi, or the Listeria? Hi staff, I am from Jaipur. यहाँ पे चांद निकल गया आई गेस, देखा नहीं मैंने भी. Okay, so what is the answer? Which of the following is a fungus? Now, Klebsiella, Clostridium, Listeria, they all are the bacteria. Now, talking about the pneumocystic cerevisiae, that is a controversy. It is a considered to be fungus. Now, before it was not considered fungus, but now because on the basis of the chitin that is present in the fungus, characteristic feature for the fungus is present the pneumocystic cerevisiae. Apart from the molecular studies, apart from doing the molecular studies, and that is about the rRNA, it is considered to be a fungus and it is easily stained by most common fungal stain that we use for staining the fungus, and the best stain that is the GMS Gomoris methanamine silver stain. It is considered to be a fungus that is Neuromocystic cerevisiae. A patient of the acute leukemia is admitted with the febrile neutropenia, and on day 4 of being treated with the broad spectrum antibiotics, his fever increases. X ray chest shows the bilateral infiltrates. Which of the following should be the appropriate next step in the management? To add an antiviral therapy, to add an antifungal therapy, add cotrimoxazole, or continue chemotherapy? Thank you, and I appreciate that. Jaipur is beautiful. It is so. Okay, so talking about the questions on the day patient is admitted with the febrile neutropenia, and on the day for being treated with a broad spectrum antibiotics, his fever increases and X-ray shows X-ray chest shows the bilateral fluffy infiltrates. Now we have already given the antibiotic and the patient is not having any relief, and the X-ray is showing the bilateral fluffy infiltrate with the febrile neutropenia, and it is seen where in the pneumocystic cerevisiae, and in the pneumocystic cerevisiae, cotrimoxazole is the drug of the choice because typical antifungal treatment is not given because it is not clearly a fungus, and there's still controversies, but it is now to be considered as fungus based on the points that we have discussed in about, but we have to give the add the cotrimoxazole for that of the pneumocystic cerevisiae. Now, coming to the question, a young man aged 30 years presents with a difficulty in the vision in the left eye for the last 10 days. He is immunocompetent and the farmer by the occupation comes from a rural community and gives history of the trauma to his left eye with vegetative matter of 10 to 15 days back. On examination, there is an ulcerative lesion in the cornea whose base has raised soft creamy infiltrate. Ulcer margin is feathery and the hyphae branching aseptate hyphae were noted. There are few satellite lesions also. Corneal scraping shows the sickle-celled macrocornidia, which should be the should be the probable diagnosis at the fusarium, aspergillus mucormycosis or the dermatophytes. Okay, so what will the answer? Now, one very important point is the sickle shaped macroconidia, which is specifically seen in the fusarium, that is specifically seen in the fusarium. And the fusarium, that is the filamentous fungus which cause a range of the opportunistic infections and involving the nails as well as in the cornea, causing the keratomycosis, and in the immunocompetent person as well. And patient presenting with the ulcerative lesion in the cornea, and very important diagnostic point, that is a sickle shaped macrocornutia which is seen in the fusarium. Fungal toxin causing the liver cancer is alpha toxin or the ochratoxin, fumonisins or the trichothiocins. So which of the following is the fungal toxin causing the liver cancer? So what is the answer? Fungal toxin that is causing the liver cancer is, it is what, alpha toxin or the mycotoxin. And what is the most common agent? That is the aspergillus flavors that is responsible for the as this alpha toxin or the mycotoxin. And what is the source we get? That is in the nuts and the peanuts as well as in the maize. And what is the clinical condition associated with responsible for causing the cirrhosis, childhood cirrhosis, and the hepatitis, liver cancer, hepatoma, and the race syndrome. So remember, alpha toxin, that is a mycotoxin released by what? Aspergillus flavus. Now, drug of the choice for the pneumocystic cerevisiae is cotrimoxazole, penicillin, amphotericin B, or the cotrimoxazole. So, drug of the choice for the pneumocystic cerevisiae is, it's easy because we've already discussed about the drug of the choice for the pneumocystic cerevisiae. We do not give the typical antifungal drugs against the pneumocystic cerevisiae. The drug of the choice is the cotrimoxazole. That is the drug that is given for the pneumocystic cerevisiae. Again, one more opportunistic deep mycotic infection responsible for causing the bilateral interstitial pneumonia. And they shows on the GMS. We'll see the image. They shows the ping pong ball appearance. So now come to first image. We'll quickly complete the image because image based session for the mycology has been done. So we'll just take 5 to 10 minutes to cover the images. So this is Tinea versicolor or Pitriasis versicolor, one of the superficial mycosis, and you can see the hyperpigmented non-scaly patch over the back. And we see what the spaghetti and the meatball appearance, or what, that is also known as the banana or the grape appearance. All right. Now, another coming to next image. This is, So this is what? This is the white nodule or the white petra. What is the causative agent? What is the causative agent? That is the trichosporon. And it is also again one of the superficial mycosis, and that is less firmly attached, to the hair shaft, so easily can be removed. And what is the most common site? That is the pubic hair. So superficial mycosis, white nodule, white peter, trichosporum visually, that is the causative agent and less firmly attached. Now coming to the next image, this is the black nodule or the black petra. And what is the causative agent? That is the Petra horte, that is the causative agent, and it is firmly attached to the hair shaft and not easy to remove, and scalp hair is the most common site. Next image. This is one of the dermatophyte, and which one? So this is what? This is the pencil shape. This is the pencil shaped and dermatophyte, which is belong to the Deuteromycetes or the fungi imperfecta, which includes what? It includes the dermatophytes, it includes the candida, and it includes the systemic fungus. And it is pencil shaped, that is the trichophyton. So this is a macroconidia, that is a pencil-shaped macroconidia with the few microconidias that is there. So that is the pencil-shaped macroconidia and belong to the trichophyton dermatophytes. Again, important superficial mycosis. Now coming to the next image, identify the image. This is the spindle shape or boat-shaped dermatophyte. Which dermatophyte? That is the microsporum dermatophyte. And it, you can see this is having many macroconidias and few microconidias. All right. So that is a pencil-shaped or the boat-shaped macroconidia, that is the microsporum, and the trichophyton tri, that involves the skin, hair, and the nails. Microsporum, that is the skin and the hair, and then we have the epidermophyton, that is involving what? The skin plus nails. Coming to the next image. This is the club-shaped. This is a club-shaped macroconidia, which belong to which dermatophyte? That is, we are left with only one dermatophyte, that is the epidermophyton, and which involves what? The skin plus nails. Alright, so this is the club-shaped macroconidia, that is having macroconidia but no microconidia. You cannot see the microconidia in the image, that is having the club-shaped macroconidia with no microconidia. Coming to the next image. Yes, so this is the Sporotrichosis shanki, That is also known as the rose gardener's disease, and you can see the chronic ulcerative nodular lesions along the lymphatics. That is the characteristics for the Sporotrichosis shanki. Identify this image. Easy one. This is the cigar shape asteroid body. Seen where? Seen again where? That is seen where in the Sporotrichosis shanki. Coming to the next image, identify the image. We already covered in detail the images in half an hour session, few days, 3 to 4 days. We are just revising it quickly. This is the copper penny or the muriform body, copper penny body, muriform cells, or the medlar bodies, or the sclerotic bodies, which is seen where? Seen in the Chromoblastomycosis. Coming to the next image, identify this one. This is the Rhinosporidium seaberry. You can see the vascular polyp. This is the vascular polyp which will bleed on the touch, and it has the white studs over it having the spherules containing what? The sporangiospores. That is the Rhinosporidium seaberry. Also, the Rhinosporidium seaberry and the pneumocystic erovisi and the locazia, they cannot be grown in the artificial media. That is, remember the mnemonic RPL cannot be grown. That is the Rhinosporidium seaberry, pneumocystic erovisi and the locazia that cannot be grown in the artificial media. And these are the spherules containing the sporangiospores, and in the Rhinosporidium seaberry, nose in the most common site followed by the conjunctiva, but it can also include other sites like the ear. Now coming to the next image. Now identify. This is the figure of eight appearance. Figure of eight appearance. And you can see this is how I wrote the eight. That is the figure of eight appearance having the broad base. It indicates what? It indicates the yeast budding form, because it is seen in one of the diamond fungus, that is the blastomycosis, and it is how write with B, this is how we write 8. That is a blastomycosis, that is a figure of 8 with the broad base, and seen the blastomycosis one of again dimorphic fungus, and this is the figure of 8 appearance. Blastomycosis, what is the other name? That is the North American disease or the Gilchrist disease. Coming to the next image, identify this one. Yes, this is what? This is the cartwheel appearance or the pilot wheel appearance seen in the yeast budding form, where in the paracoccidomycosis we see the cartwheel appearance or the Mickey Mouse appearance. Again, another dimorphic fungus. Identify this image. ज्यादा बातें गपशप करूंगी तो मेरे को निकाल देंगे अनअकैडमी वाले. So this is what? This is a germ tube test This is the germ tube test or the Reynolds blot phenomena that is seen in the Candida albicans and the Candida dubliensis. So this is seen in both the Candida albicans and dubliensis, that is the germ tube test. Identify the next image. Yes, identify. This is the Cryptococcus. You can see the capsule and what the stain we use, that is the India ink stain or the Nigrosin stain or the negative stain to stain the capsule of the Cryptococcus. So coming to the next image. Now this is the Aspergillus. Okay, this is the Aspergillus and you can see the septate hyphae with that of the acute angle branching seen in that of the Aspergillus. Now moving to the next image. Yes, so this is the ping pong. This is the ping pong ball appearance. Seen where? Seen in the pneumocystic aerobacilli. Or it is a ping pong ball appearance seen under the GMS, that is the Comoris methanamine silver stain, and that is the ping pong ball appearance. The capsule, the cell wall is stained as the dark black with that of the green colored background. Come to next image, important one. This is again Aspergillus A4A, that is the acute angle branching with the septate hyphae. This is again Aspergillus. This is the Aspergillus with the acute angle branching, and this is the broad hyphae with the obtuse angle branching seen in that in the mucor or the zygomycetes, that you can see the right angle branching and the broad aseptate hyphae. So that was it about today's session. Thank you so much, and please do use my code, that is Muskan10, to get 10% of the discount. And I'll see you again tomorrow at the same time tomorrow on the YouTube. So see you soon, and do like, share, and the comment, and follow me on the Unacademy app as well as on the channel. So take